We're going to divide into 3 sessions. The first one, for half an hour or so, we'll ask each of our panel members just to outline some of their key reflections over the last few months on some of the achievements, on the whole the innovation that's been shown, and as we look to rebuilding. So get some of their reflections on that. Then we have a series of individuals who've identified themselves to ask a number of questions, and they know who they are and are expecting me to come to them. So we'll have some questions from them and an opportunity maybe for a little bit of comment on each of those. And then the last session is to try to involve as many people as possible and make it as interactive as possible. So we'll be encouraging you all throughout to please use the chat function heavily. Heather Moorhead and Megan from NICON are going to be monitoring closely that chat function and trying to pick up some of the key themes and issues that are raised, and we'll have some more open discussion around those towards the end. I'm sure by now everybody is really familiar with using Zoom. It's what most of us do most of our business on most days. 200 people registered for this, and I'm not sure how many we've got at the moment. It's just half of that, but we have hit the 100. Having 100 people on a Zoom call certainly new to me and could be a bit of a challenge. So can we please ask, and this might be being done centrally or controlled centrally, but please mute your sound unless you are speaking. We're also going to ask everyone, and again, it might be able to be done centrally by Megan. I'm going to ask you all to turn off your video unless you are one of the people who are speaking, just so the screen isn't too fussy and you can easily see who is speaking. We'll bring everybody back on towards the end of that. As I say, please use the chat function heavily throughout. Just to let you all know, the session is being recorded. It's our intention to be able to share it more widely, so please just everyone be aware of that and be mindful of it. We've got it down, the session down to end at 2:30. We will aim to be as close as that, but we will allow a little bit of flexibility there if the discussion is still going on. But please, if anyone does need to leave sharp at that, or indeed at any stage, please feel free to. We know how busy everybody is. So to kick things off, I'm going to ask Richard if he would maybe just make a few opening remarks, give us his thoughts as he looks back on the last few months and his hopes and concerns looking forward to over the coming months and the rest of the year. So Richard, over to you.
Thanks very much, Michael. It's difficult to know where to start in terms of any reflective piece. I think the best place to start is absolutely an acknowledgement of the work that has gone in from colleagues across the system and offer sincere and heartfelt thanks for that. I think if we go back a few short months when we were launching into the unknown, the initial modelling, the numbers that we were showing for potential deaths and infection rates have thankfully turned out to be far in excess of what we actually delivered. I think that was very much a combined effort on the part of the system and the community, and I don't think we should ever underestimate the role the community played in this. I was looking today, the Nuffield Trust produced a league table of the 13 regions across the UK and the cumulative number of cases per 100,000, and of the 13, Northern Ireland was sitting, I think, in 12th place, which is a fantastic achievement, and I think that speaks to the way the public responded to the restrictions. But I think separately, and there's part of me is deeply uncomfortable in talking about the comparative death rate across regions, because it's not a competition, and I wouldn't ever want to say, you know, however we did, we're better than someone else. But and I think that's a better reflection of the way the system responded. And again, at a UK level, we're certainly the lowest. We're not on a par with colleagues in the south. So I think those broad indicators reflect the huge achievement at the macro level. But I think when you drill below that, what's really impressed anyone who's had engagement with the service has just been the way the system has come together. We've broken down silos. We've worked collaboratively and collegiately across organisations. At an individual level, people in the system have quite happily effectively put their own personal lives on hold to offer a huge commitment to the service. And as I say, we can't ever properly express our gratitude for that. If I can just temporarily climb upon my normal hobby horse at that stage to say that when colleagues have done that and colleagues have committed, I do mean all colleagues, the media still love to wax on about the front line. And I don't denigrate, the front line has been absolutely magnificent, but so has every other individual working at every role across health and social care. And each and every one of us, I think, has an equally important part to play. And that work and effort has been amazing. I think I'd also pay tribute to the way primary care in particular has responded and engaged with colleagues in secondary care and beyond. I think one of the big learning points for me in our response is, as a system, we've achieved some things that probably we've aspired to achieve for a very long period of time but have been unable to. And by that I mean new ways of working, more agility. For our part in the department, we've been able to develop policy interventions and offer approvals for things that would normally have taken a very considerable period of time. So we've been able to move very, very quickly. In terms of where we go from here, I think that the single biggest mistake we could make, as some have said, is to seek to take our system back to where we were in December and January. We've spent the last number of years saying that our system and its configuration was fundamentally flawed. So why would we want to go back to that? We need to use this opportunity to take the good bits out of which there are many, out of what we've achieved over the last couple of months, and aim for a new landing site, which is the sort of configuration of services that we know best serves the needs of the population. So hence the establishment of the management board. I'm sure we'll say a bit more about that later, but that's fundamentally not about seeking to directly control work across the system from one central point. It's about making sure that we take a common regional approach to issues, that system leaders come together on a very regular basis. It's trying to capture all the things that happen through personal effort. So I think, equally, sorry, I should say, none of us will claim that we got everything right along this journey. Of course we made mistakes, and it's important that we both acknowledge those mistakes and learn from them. And particularly as the prospects of a second surge later in the year, we can't just blindly do what we've done, but we are endeavouring to do that. But for me, the big thing is the commitment and effort of colleagues, the way we work together. I think the circumstances have required us to empower people in a way we've never done before. That's proved to be hugely effective. With a management board meeting yesterday, and John Maxwell was presenting on urgent and emergency care, and particularly some of the lessons he had learned from looking at other systems. And the one thing that comes through for me is that high-performing systems have a huge element of trust across that system. And it's trust and respect for individual colleagues and what they bring. We all bring something different to it. And I think, for me, that's the key point we need to build on going forward. But if I just finish those brief comments by again repeating sincere thanks to everyone for, I think, what has been a magnificent achievement. And please, as things settle down, I implore everyone on our system, please try and take some downtime and recharge your batteries, because it's certainly needed and deserved. So that's all I wanted to say, Michael, by way of intro. Okay, thanks, Richard. No doubt we'll develop some of those points, but a particularly important one, I think, that issue of and something we need to make sure that the wider public understand. This is not about getting us back to where we were pre-COVID, and the term is quite often used about recovery and returning to normal gives that sense, whereas I think it's an important point you make, that we're keen to build on where we are and move forward. Also encouraging to hear that statistic that NI features on the league table, and I take your point about it's not a competition, but it's good to see that we feature in the right end of a table, because so often
the media are keen to highlight the examples where we don't. So it is good and a testament to the hard work of lots of people and the significant and the responsible approach by the wider community. So thanks for that, Richard. If we could turn now to giving a bit more thought about some of those key achievements over the last 3 to 4 months, and ask Charlotte McArdle and Alan Stout if they would each just in a couple of minutes each give us their thoughts and reflections as what they see as some of the most significant achievements over the last few months. So Charlotte, maybe come to you first.
Okay, thanks, Michael. I think I'd like to start with a further acknowledgement of what Richard has said, because I think as a system, it's been hugely impressive to see what has happened over a very short time at a system level in order for us to be able to provide the level of care for the number of people that was required so quickly. And at a personal level, I think for those I've spoken to, or those who I know have, had to change their work location or change how they've managed their service or worked in an environment that they weren't particularly familiar with, the personal stories attached to that has been pretty much, I think, overwhelming for all of us who've heard them. So at both a system level and a personal level, I think everybody has really put their shoulder to the wheel here to make sure that we have got those very good outcomes that Richard has mentioned for our population at large. And I suppose in reflecting on that, it shows me what we can achieve as a system when we really focus on getting the job done. Everybody's pointed in the one direction. Everybody's aim and ambition was to get through the pandemic with saving as many lives as possible and being as compassionate about that as we could. And even though the system was working full tilt, over 100%, working in different ways in very fluid and challenging circumstances, it was done in a very compassionate way, particularly for patients and families, given the very difficult restrictions we had put on visiting, etc., but also for each other and helping and supporting each other day to day in teams, whatever those teams were, whether they were frontline teams, as Richard has said, or managers or at the department, helping each other out and really playing a full part. So I think for me, one of the key learning is that we can do whatever we want to do as a system when we all move in the same direction in unison with each other. I think that trust is also a very important issue, and again, just thinking about practice where you were working in different teams with different people, you had to trust them and their ability to do the job, and I'm not aware of anybody letting anybody down, so everybody was able to reach the standard that was required. And I was reflecting on, I'm sure most people will have seen Niall's diary that he wrote whenever he moved from orthopedic surgery into ICU in the Nightingale, and that just for me manifested all of the good things about our health system, about how we worked with each other, trusted each other, maximised opportunities for learning even in difficult situations, provided the best care, and got through a very difficult phase together. So, thinking about some of the specifics, and the risk of doing this is that I'm not going to cover them all, and I'll leave some out, so apologies if I do, but just thinking about the major achievements, I suppose I'll start because with the surge plan, because that's what I was leading on at the time, and the development of the Nightingale Hospital, which was turned around in less than 2 weeks. I'm absolutely amazed by the support of the system to make that happen. All trusts coming together, but particularly the Belfast Trust taking the load on this in terms of making the Belfast City Hospital a Nightingale Hospital. Thankfully, we never needed to use it to the level that it was made available for over 200 ICU beds. But just walking around in it, getting it ready for opening, and seeing the level of work that had to be done and how quickly that had been turned around was quite amazing, really. The introduction, the expansion of the testing program, again, so many people were involved in that, right from agreeing what the protocol would be, to training staff, to getting the PPE, to making the facilities available, and for getting people their testing, with over 70,000 individuals being tested so far, and a key part of our ability to treat people and manage the pandemic. And I think leading on from that, the test, traced and protect strategy, which in the future will even be more important than it has been to date when we move into local outbreaks or nosocomial outbreaks, where we can use that strategy to help us deal with that going forward. And because we know now that COVID is going to be part of our life for the next 18 to 24 months, we've got to try and maintain some degree of normality for service, but at the same time manage the pandemic outbreak. And I think that strategy is going to be key to do that. And again, that's something that's been turned around in a matter of weeks, which potentially in normal working might have taken several months to do so. I think there has been and continues to be, and I think going forward, a huge opportunity to work more closely with the private sector and to partner with them as real partners in developing our services on many fronts. You know, certainly in terms of care home provision, much more close working with that sector, understanding their issues and how we can work together. But also, you know, working with local companies when we were really stuck for PPE, you know, companies like Block Blinds and Denroy Plastics coming forward to make visors and shields, which until that point, I have to say, across the UK were in very short supply. And certainly there were very limited numbers of visors in the stockpile that we had. So our ability to do that as a population supporting the health service was amazing. An outstanding feature for me is the COVID centres, I have to say. And I know Richard said, particularly pointed out the response from primary care, but that has been truly amazing. And I do pay absolute tribute to colleagues in primary care for changing how they worked and being able to staff and man those COVID centres. And I think they have a real purpose in the future. And it would be a shame to see us go back when we have so much, we've achieved so much and so much more to do in terms of the COVID centres, if we can just work together to find the right solution for them. But that model, I think for me particularly, has the focus in the future to help us continue to change the health service. And the childcare, even, you know, the childcare strategies, allowing our staff to have childcare facilities so that they could work, but also for other key workers. The investment of 12 million on that front to support again the health service and its workforce is another key feature. I mentioned briefly the nursing home sector, and I think that is a real focus for us going forward. We know that that particular group of people are particularly vulnerable to COVID, and we have learned quite a bit, and you'll be aware of the rapid learning work that's currently ongoing with the independent sector, taking the learning from Surge 1 and factoring in what we would need to do should we have a second surge in the autumn. And also the work around acute care at home and trying to standardise and agree that and provide better support to the independent sector. I think that, again, in reflecting, that's one of the things that stood out for me was the number of people in the care homes who, for example, were requiring respiratory support on NIPI or NIV. Or while I thought there would probably be a few of those people, actually the numbers are much bigger, and the level of complexity that people are having to deal with in care homes is continuing to go up, I suppose. And I don't think as a system we've really put the wraparounds in for those people to be cared for in their own home, and that's something that we're going to look at for the autumn and the winter. Other things to note, I think the workforce, particularly the early registration of students across all the professions. I mean, every single profession, their final year students in particular, were so willing and wanted to come in and support the health service. I actually looked forward to it. They were nervous, of course, about the risks, but with the support they got from the system, that has worked really, really well. And actually it has enabled on the AHP side, the third year students to be registered a bit early and ready to practice to help with the rebuild, and the same on the nursing side. So I think there are a number of key things that we have achieved, but for me, my biggest reflection is that we have shown that we can really, as a system, achieve huge change very quickly, and I think we're 3/4 of the way up the hill here, and we need to stop ourselves going back down. We need to get to the top and push on with our transformation period now.
Okay, thanks, Charlotte. As you say, there's been so much good work. It is the risk of trying to single some things out, but I think that's an important point you make, that the way people worked and the speed with which things were done and the confidence it should give us for moving ahead is probably one of the most significant things. So thanks for that. Alan, can come to you, just the same issue, please, and give us some indication or sense of what you are most proud of looking back as to what the system achieved.
Yeah, thanks, Michael. I'm going to give you a very broad one and then a GP specific one, and I'm probably going to echo a wee bit of what Richard and Charlotte have already said. And I think it is important to say, just from a clinical perspective, and this is the broad achievement, the fact that we're actually sitting here now, and as you said in your introduction, that we're looking back and reflecting on the first phase, that we're already starting to talk about a reset and a rebuild and a restart and so on, is very, very important. I'm going to start my video, although I'm on my phone and I'm not entirely sure how I do.
You're trying to be very adventurous here, Alan, so have we lost you? I think we maybe have. There's no video.
Sorry, no, I'm still here, but I don't have my video for some reason. But the topics that we're discussing today, Michael, the topics that we're discussing today in terms of the rebuilding, you know, again, is very, very encouraging from a clinical perspective, and it's very, very important that we do harness that. I think what we do face as well is the inevitable reviews, the inevitable queries and the inevitable criticisms. But even looking at those as a positive, the fact that most of those are now being talked about as operational issues rather than a service collapse or thousands of deaths, which were predicted in the early stages, I think that is very much a positive. And I think we can all deal with a look back on operational issues. But if we were looking at a much more catastrophic scenario at the moment that was at one time predicted, we would have been in a very, very different space. I think that is solely down to people. I think it's down to the people on the panel. I think it's down to the senior decision makers and the decisions that were made very quickly and very decisively. I think it's also down to clinicians and the ability then to adapt and change. And then also, and I think Richard mentioned this, the patients and the public, and following the clear advice, and it was very clear advice that was given. I think not one of us is complacent and can't be complacent about what we might still face in the future. But again, just then for the specific example, is Charlotte mentioned it just at the end there, was the example of the COVID centres, which in primary care we set up extremely quickly. We set up in just over a week. They were absolutely critical in terms of two key principles that we set out at the outset. One was that there had to be a strong primary care response to COVID, which was so important, and the emerging evidence was that was so important to protecting the hospital sector and protecting them from becoming overwhelmed very, very quickly. But second of all, what it enabled us to do was to keep practices open and clean. And that again was in recognition that even within a pandemic, until it gets to the absolute crisis stage, we are still going to see more morbidity and likely more mortality from other things than from the pandemic itself. So we were very conscious of keeping practices open and running through that, and they have done through the whole pandemic. And again, practices have adapted and changed very, very quickly just in terms of how they do that. Even within that time period, the COVID centres themselves were able to change and start to introduce various testing and some of the tracing, and also start to contribute very significantly to the care home response. So just to conclude, again, it's an example, it's not a specific primary care example, because the work that went into this was very much working together with our trusts, our trust colleagues. And I think it is important as well to mention the huge input that we've had from medical students within the centres as well, and just the amount of work that they have put in and the amount of help that they have given us.
Thanks, Alan. And again, you know, lots of good points, but particularly just that early thought that you had that we are sitting here looking back to learning and lessons and how we move forward, as opposed to perhaps looking back at a much more difficult position, is something that everybody should take some satisfaction from. Richard and Charlotte both mentioned the role of primary care and, you know, a considerable reduction of silos. You mentioned the COVID centres. I have to say, I really have sensed over not just the last 3-4 months, but it's sticking with us as we start to look forward, a much closer working and much more around whatever the system needs to do for the best interests of the patient. I think I'm feeling that stronger now than I have at any time over the last, 10, 15 years. So we need to make sure we all continue to harness that and build on it, as the only way to really move things forward. So thanks, Alan. So Charlotte and Alan, looking back, let's say, with some reflections on key achievements the last 3-4 months, starting now more to look forward. And we asked Seamus McGoran from South Eastern Trust, maybe give your thoughts, Seamus, in relation to how we plan to rebuild and restore services. And I know you'll be coming particularly from a trust perspective, but thinking right across the system.
Yeah, Michael, I had thought the Chief Medical Officer was going to do all of the talk and pick up all the salient points on this one, and I was just going to come in and sweep in at the end, but obviously that's not possible, so you're stuck with me. I'm not sure whether it's 2 to 3 minutes or whether it's 6, but I suppose I'll give you my thoughts in general. I think there's a couple of general comments I would want to make. The rebuilding challenge is probably going to be substantially more difficult than the initial surge that we actually had to deal with. And you won't need me to tell you about the complexities around trying to create social distancing, the whole issue of making physical adjustments to our environment. The workforce availability is still a massive challenge for us, and of course PPE among many other things. So there is something about a gradual planned rebuilding that we're all working towards, and at the same trying to keep our staff on board with that, our trade union colleagues, messaging to the public about what it is we can actually achieve. Because when you think about it, we've had a really tough 3 months. Our staff will need a break over the summer, and we probably won't be able to deliver the level of increased activity that we would want to. And we've so many of those risk assessments to undertake to make sure we're keeping staff safe. But there's lots we can do. And I think when I look forward to some of the main priorities, I suppose they split between service and general. I think the first thing for me is we absolutely must learn from the past 3 months. There have been lots of new ways of working that Richard, Charlotte and Alan have already referred to, as you have, Michael. Such a rich opportunity. That's one of the big priorities for the Rebuilding Services Management Board, and we're using a QI approach to that to pick up all of that innovation, and through the 90-day cycle, I think we have an opportunity to take that learning at pace when you think about how the big ship normally turns in health and social care. From some service perspectives, obviously mental health is a big one. We've always known that it's been a challenge in the system, and the level of increased mental, I suppose, non-well-being is maybe a way to describe it, that we've probably seen in the system over the past few months is just ever increasing. Alan Stout referred to the level of increased mental health issues not really being the sort of traditional medicalized mental health issues, be it psychosis or bipolar disease or whatever those conditions might be, but much more, I suppose, a high-level social stress, which nonetheless is really a big issue for every citizen who's experienced that, and we really have to take an opportunity to address that. I think actually primary care, through the multidisciplinary teams, is very well placed to actually pick up that before it becomes a bigger issue. Cancer has been highlighted as one of the main priorities as well for the service. When we look at some of the reductions in red flag referrals, outpatient assessments, diagnostics and treatments, we know we have a lot of catching up to do. So obviously cancer, another one. I think there is a priority that we absolutely must grab in terms of the interface between primary and secondary care. We've seen really good working, and I know our GP colleagues have been shouting about this for years. Can we have some better communication and engagement with our secondary care colleagues? Because that way we can stop people actually joining long waiting lists, which I'm going to touch on later on. You've already mentioned urgent and emergency care. Huge issue, consumes a lot of our resources, and patients and the public wait far too long to get access to timely emergency care. So we really need to take this opportunity to deliver that change. And of course, elective care, which I'm going to mention earlier. There are a few other issues that I think are a priority for us: looking after the health and well-being of our staff, further surge planning, the whole issue of stock management and testing. At a delivery level, we're having to, I suppose, almost replicate our colleagues in BSO who are experts in stock management and in terms of the ordering, supply, receipt, distribution, and management of stock. And I have to say, I think everyone has done really well getting up to speed on this, but we need a much more sustainable solution going forward. And I suppose another big priority as a general comment is the importance of actually real, effective, meaningful engagement with our staff, with our trade union colleagues, with the public, with all of the key stakeholders, including our politicians. And the challenge there is, how do you do meaningful engagement when we need to deliver transformation and change at pace? That's a biggie for all of us. If we want to do it well, then we engage effectively, but it will require people responding swiftly and not the usual prolonged levels of consultations that we would have done in the past. So they for me, are some of the lots of priorities. There will be many more, but we can't prioritize everything, or nothing will be a priority. And how's it going to work? Well, there's a very clear executive authority line within the management board on behalf of the minister, and that's the opportunity for us to really make substantial change in a way that we've been crying out for since Donaldson, Bengoa, delivering together, transforming your care. This is a real opportunity, and if we don't take advantage of this opportunity, I don't think anyone will forgive us. So it depends whether your glass is half full or half empty. I see it as a real opportunity. There is a clear executive authority within the management board to make things happen. The management board is very clearly aware of the importance of engagement. And I think at a trust level, there's still clear accountability for the vast majority of what we do every day, actually. And we're still responsible for all of our services, our governance, our financial management, all of our statutory responsibilities. Nothing will change in that respect. And we're also going to have to be accountable for delivering and implementing strategic changes that are taken and decisions taken at a regional level. I think most people are getting their head around that, albeit there will still be lots of questions that people will have. I know some of our non-executive colleagues, and indeed some directors will no doubt just be trying to find out how do we make absolutely sure that the accountability arrangements can ensure there's no omission or overlap in the services that we provide or the decision-making processes, and that we need to be mindful of unintended consequences. But we're on a journey. I think we're going to learn to some extent as we go along, and I think sometimes it's about a state of mind as much as anything else. Where there is a will, there's most certainly a way. And I think if we can crack the engagement bit and do it swiftly, then I think we have a much better chance of delivering meaningful and effective change. Just picking up on Charlotte's comment, we're 3/4 of the way up this hill. It's not just that we don't go backwards, we need to crack on and reach the summit.
Okay, thanks, Seamus. I think you've very clearly set out the scale of the challenge right across so many areas there, and therefore the need for the systems that are being and the oversight that's being put in place to make sure that's all done at pace. You've touched on a few issues that will come up later on in the questions around the impact on mental health in the community, and indeed the governance around the new management board. So we will return to those, but I think you're right to highlight that in all of the challenges that need to be taken forward, key in doing it and necessary, essential to do it effectively, is the staff to take it forward. And we need to recognise that the really difficult 3-4 months they've been through on the back of a difficult winter, let's not forget, immediately before that, and we do need to make sure we really look after their health and well-being, find ways for people to get that break and recharging that they need over the weeks and months ahead. Otherwise we'll not be in a position to move on. So thanks for that. There's a few things you've raised we will definitely return to later on, Seamus.
Thanks, Michael.
And then lastly, in this first session, again, everybody so far has mentioned about the innovation and so on. So I'm going to ask Jennifer Welsh and Sean Holland if they would just expand on that a bit more and say how they see us going about capturing that learning going forward and truly embracing innovation to make the most health gains for our population. So Jennifer, come to you first, please.
Okay, thanks, Michael. I think from a fairly early stage, from a trust perspective, first of all, we were quite keen to make sure that we were capturing the learning as we went along. And all chief executives had engaged through their heads of quality improvement to make sure that we were trying to capture that, working closely with teams. So I would say there's learning at a very local or service level. There's learning at a broader level in terms of an organisation or an area or a geography. And obviously there's a learning at the regional level as well. So as I say, quite early on, Trust Chief Executives, we had decided that we wanted to grab this from a systematic perspective, and we had engaged with the HSC Quality Improvement Alliance. But I'm delighted to say the service delivery innovation is now part as one of the key work streams from the HSC Rebuilding Management Board sitting under Richard. And we're going to use that quality improvement approach as we move forward. And I suppose we've all come at this in terms of trying to capture learning at a very individual team level. Certainly that's what's going on in my organisation. I know it's the same elsewhere as well. So lots of detail from different teams about what they did differently during this time, what the outcomes have been. But it's not just about how has that worked on the ground. I think one of the really important things is what did that feel like for the staff member, perhaps delivering the service in a different way? What did it feel like for the patient or the client or the family or the carer experiencing that in a different way? So it's to try and capture that experiential aspect of it as much as it is about the what did we actually do differently. So I'm not sure if Sean's on because he was wanting to talk a little bit about that, Michael, or I can keep going.
Sean, I haven't seen him yet, but there's quite a lot of people to see. Sean, are you there?
Michael, he texted me to say he tried to log on, but he got a message saying maximum number of participants reached.
Yeah, apologies for that. I was going to say that just between sessions. Although
Michael and Richard just.
Yeah, we have facility for 300. For some reason, at 100 they stopped letting anybody else in. So it is sorted because I see we're up to 134 currently. But there was a bit of a delay. So sorry for those of you who joined and missed the start because of that. Bigger sorry to those who gave up and thought there was a problem. So it sounds as if Sean is one of those. So Jennifer, are you able to elaborate on that a bit?
Yeah, happy to keep going. I suppose just in terms of the experience, I'll give a couple of different examples. And talking just particularly from the innovation perspective, I think one of the great things has really been the use of digital technology. So there's so many areas have really embraced that aspect of digital, and things that we perhaps initially thought that we weren't going to be able to deliver, we have done because we've done it in that virtual way. So outpatient consultations that we're able to go ahead digitally, either via Zoom or FaceTime and things like that. Even family contact in a lot of our children's services, we have been able to maintain in a virtual way rather than a face-to-face contact. And that has been really important for families throughout this. I think one of the other things that's been really difficult because of no visiting over this period is how did we support patients and families when their loved ones were in hospital. So even practical things like iPads in the middle of intensive care units, so that you could make contact with families so that they could see their loved one there. That's all been really, really important. And I would also think about the experience in care homes. I'm not long from our trust board meeting this morning. We had one of our locality managers talking about his experience of what it felt like to go in and support a care home in a very intensive way over a 3-month period. The personal impact that it felt for him and his team, what they felt they brought to that, what it meant for families who knew that they were in there supporting their loved ones as well. So I think that engagement piece and the learning from experience is almost as important as the what did we actually do to change things. And I suppose the other thing I wanted to mention is the potential that we've had to unlock things. So I've spoken to so many clinical teams throughout this, and they have all referenced things that they have maybe wanted to do for quite a long period of time. And the COVID pandemic has enabled us to unlock and start things that it was maybe going to take us a really, really long time to deliver. So in my own organisation, we had plans to create an emergency surgical assessment unit. Now it wasn't due to come on stream probably until the end of the summer, lots of the planning underway, rotas being established. And we realised going into this, we're going to have to find a way. EDs are going to be overwhelmed with COVID. We need to find another pathway that GPs can safely refer into if they feel somebody really needs an emergency surgical assessment. So the clinical team decided that they were going to do it, and in a matter of weeks, that was something that we had up and running, and we really didn't think that we were going to be able to manage that. So I think there are so many fantastic things that we have started, that we have unlocked, or new things that have emerged simply out of necessity. But the good work is going on within trusts, across trusts, and importantly, at a regional perspective to capture all of that learning. And I just wanted to pick up on what a number of people have mentioned earlier. I think one of the exciting things is, and I'll talk about it later on, is the breaking down of barriers and not working in silos, doing things across those traditional boundaries, so across primary, community, and secondary care. So some of the learning out of that, working across patient pathways and not being restricted in the way that we have perhaps perceived we have been in the past, has been really quite extraordinary.
And Jennifer, what would you see is the single biggest thing that we need to do to make sure that that pace of change, that unlocking that you described, doesn't go back to the way it used to be? So it's as if everyone realized there was a permission to do things differently and a permission to almost do things outside of normal process and structures. And I know the Rebuilding Management Board is all about that, about driving forward in those 3 monthly cycles. But just in terms of how people themselves behave, what do you think we need to do that they carry on, that becomes the norm as opposed to something you do in a pandemic?
Yeah, I know we'll be talking about this later on. I'm tempted to use the phrase about seeking forgiveness and not permission. I think there was an awful lot of that through the pandemic. I think one of the things that's worked really well is the things that have been clinically led and managerially enabled. Going and talking to the clinical teams, there are fantastic ideas. And I think what we as a system have done is to find a way to wrap around them and unlock the really good ideas that are there. I think this is going to take energy and pace, Michael. I think we're going to have to continually drive this. And there's a danger, I think, in terms of us sustaining that energy to actually go forward. It was all there at the time of the pandemic. And we know as we get into the trough, I suppose, between peaks, it's easy for the energy to dip, and we can't actually afford for that to happen. I think we have to take a lot of the learning from some of the work that our colleagues from mental health and wellbeing have done, looking at the resilience of people and what it is that we need to be doing to support teams to keep those energy levels up. So it is important that people get a break at this stage because they're tired and they do need it, and that equally we can come back energized and with new ideas of things that we really do want to take forward.
Okay, thanks, Jennifer. Again, I know we will pick up on a few of those things as we move forward. So, folks, we'll move into the questions. Can I remind you again about, I see lots of comments coming through in the chat. Keep it up, please, because we will try to bring all of those together and highlight some of them at the end. And again, for anybody who's just joined very recently, apologies for whatever technical problem we had that initially was stopping it at 100. So I know there's a few of you who have really just joined in the last few moments. But moving on into the questions. So the first question we have is from Anita Rowe. Anita is AHPQI lead in Belfast Trust, and she's got a question about waiting lists, waiting times, which we're going to ask Seamus McGoran to kick off by responding to. So Anita, hopefully you're there and unmuted and
yes.
Ready to go.
Great, thanks Michael. Yeah, so I just have a question, as you say, around waiting lists. So pre-COVID, the HSC was already under huge pressure, and we had unenviably long waiting lists which weren't acceptable to anyone. So really my question is around how are we going to address that issue? Are waiting lists just likely to get longer? And will we be able to access the funding and indeed the workforce that we need in order to address this?
So good to start with a really easy one. Thanks, Anita.
No problem.
Talk about waiting lists, funding and workforce. Okay, I'll give it my best shot. I suppose Richard has been on record as saying we need transformation and we need sustained additional investment if we're to really tackle the issue of long waiting lists, which are growing year on year. And that funding thing will be an executive decision, or dare I say, probably a Westminster decision because of the scale of it. I think Richard has quoted 750 million in the past over a 5-year period. So it will require massive investment, especially if we're going to actually try to deliver effective waiting time services on a sustainable basis. So I'm going to set the money aside now because that's in somebody else's hands. I tend to like to focus on what we can control, and there's so much we can control. We've had feedback in respect of our percentage day case activity compared to the BADS, the British Association of Day Case Surgery, basket of 25. We've lots of opportunities to actually move more inpatient work to day case work, and indeed day case work to outpatients with procedures. And we don't always have to rely on our medical staff to carry out that work. We need to ensure that we develop the workforce more and more so that nurses, AHPs, and other staff can be trained to pick up that really critical work. But part of it is also just about doing the basics. Good housekeeping. We should be clinically validating our lists. We should be ensuring that we reduce our CNAs and our DNAs, the things that are the bread and butter of service provision. We have a limited capacity and we need to maximize the utilization of that capacity. Prevention better than cure, and we need to invest further in getting upstream. I think something like the diabetes prevention program is just a wonderful example of how that proportion of the population who are in that pre-diabetic phase being supported and not then ending up having diabetes. And we all know what comes with that from a healthcare perspective. I mentioned it earlier, and others have, the interface between primary care and secondary care. We need to really open that up and create opportunities where our primary care colleagues can get timely access to specialist expertise in hospital. And it doesn't have to be a consultant, it can be a staff grade, a nurse practitioner, anyone who's sufficiently trained and has that experience in specialist expertise. And that will mean fewer patients coming on to our waiting list. It will also mean better management of patients in primary care and better outcomes for them as well. I think there's more we can do within the primary care arena as well in terms of developing very specific pathways. I know our plastic team in the Southeastern Trust have a trigger finger pathway, which when you get a bit more detail in the referral means you can go straight to procedure rather than joining a lengthy waiting list. And lots of those patients who are joining our waiting list are doing so because that's the way we've designed our system. We need to now unpick the system and make sure we're able to actually prevent patients being added to long waiting lists, and they can be well managed in primary care with appropriate support. On the modernisation front as well, if you think about the dedicated day case elective centres, we're just dipping our toe into the water. There's lots more procedures. We can expand the range of procedures, and we all know that with that dedicated approach comes the real prospect of being more efficient and developing greater expertise to deliver better outcomes. But I think we can build on that and probably look to more one-stop services and not just on the treatment side of it. We've some experience with bringing together our medical, nursing and other staff in terms of outpatient clinics. And interestingly, some of the findings from that is that our experienced nurses are better discharging patients from our services than, say, junior doctors would be. And when you think about it, why not? They're the ones with the experience and expertise. So we need to build on doing those, using best practice, fit for colorectal patients. And I do think there's something about us implementing the next phase of the effective use of resources policy. We've got a policy at the moment which just needs to be implemented so that we can focus our critical resources on those who really need it. To touch briefly on workforce, there are no overnight solutions in building your workforce. We've made a good start with our nursing workforce, and we need to do that with others. Obviously, investment is important, but there's still lots of things we can do that won't rely on investment and further training. One of the first things we can do is actually implement delivering together. We spread our resources too thinly across the region, and we weight those heavily towards unscheduled care. And I think elective care has lost out as a result of that. But if we actually implement delivering together, I think we can seize the opportunity to put more of our current resources into elective care. Lots of other things we can do around maybe our staff, our part-time workforce. Can we find ways of making it attractive for our part-time staff to take on more work, specifically elective work? I know that's not easy because of agenda for change. We need to train more and more staff to do things that doctors previously would have done. And there's a wonderful example that comes to mind from our colleagues in Belfast in the macular unit. Probably 10 years ago, it was doctors doing all the injections. Nurse practitioners have been doing most of the injections ever since. And just last year, optometrists were being trained to deliver the eye injections as part of the team. So we can continually look to other professions with the appropriate training to make that happen. And then just a last couple of points. We work in partnership with the independent sector. We've done that for many years. We've got facilities that we should be better using across the week, evenings and weekends, but we can also tap into our independent sector colleagues and get them to work with us in partnership. There's some good working across the region where we've seen that. And I suppose my final thought is that if you look at the incredible response there has been from retired staff and other staff who've stepped up when we needed them for the pandemic, we should be asking all of those staff whether they would like to do some work going forward, with a particular focus probably on elective work. We may not gain that much, but you never know. Some people might have come back and said, I quite like being in the service again. I might want to do 8 or 16 hours. And if you don't ask, you don't get.
Great, thanks. There's some really useful suggestions there. And again, let's see, can we get the positives out of the experience in the last few months of doing things differently. You mentioned a few things there that I think it's just useful to give a couple of others the opportunity to comment on. Don't want to limit you to talking about the money, Richard, but Seamus did tee that up, and Alan, clearly the role of primary care important here. So Richard, do you maybe want to say a few words particularly about the challenge of the funding to really get on top of the waiting lists, in particular the backlog?
Yeah, I mean, the reality is, and we've made no secret of the fact, if you want to get rid of the current waiting lists, you're going to have to invest a huge amount of money. That's obviously will be made more difficult by COVID and the need for an economic response, because, you know, aside from the health damage that's been caused, an awful lot of people have lost their jobs. There's going to be lots of interventions needed there, so that's going to make it more difficult. But the big point I would make in this space is I want to move away from judging the health service by waiting lists. People think it is the key barometer of how we're performing as a system. And I think in many ways we've made a rod for our own back, because if you randomly stop someone in the street, I think that the two things that tell you how good, bad or indifferent any health service is are the number of 12-hour breaches in the ED and the length of elective waiting lists. I want us to move on to a position where we judge the quality of our health and social care system. The main metric for me should be that relationship between demand and capacity on an ongoing basis. We're in the position we're in because we had a flawed configuration of services that, for a variety of reasons we're all too familiar with, there just wasn't the broad acceptance that should be changed when we were all screaming for it to be changed. The offsetting measure was an annual injection through monitoring rounds of 70 or 80 million pounds a year in terms of waiting list initiatives, just to keep a lid on it. Back in about 2014, that stopped. And no surprise, waiting lists have escalated since then. We have been saying from day one of the transformation journey, the transformation will not address the waiting lists. Transformation will put the system in a position where we better look after service users and we don't ever accumulate waiting lists in the future. But if you want to get rid of waiting lists, you need to throw a bucket load of money. So for me, the size of the waiting lists is the responsibility of the executive and wider society and the extent to which they're prepared to invest heavily in getting rid of it. Our performance measure is how we stop people getting ill, and I think that's been true in a few comments. It's not just about treating people, it's about those interventions way upstream before people get to the stage they need an elective intervention. But it's how we match demand and capacity going forward. we've made some great strides. The lessons we've talked about coming out of COVID will help us further. We need to continue to be innovative and think of new ways of working. But we need to be clear, those new ways of working will not eliminate our waiting lists as they currently sit. That will take bucket loads of money.
Okay, thanks, Richard. And obviously a challenge with getting that with a financial outlook for the years ahead, but a compelling case of needs. Alan, come to you. I'm sure you wouldn't want to miss the opportunity on this topic to say something about the role of primary care.
Yeah, no, thanks, Michael. It's funny, Seamus very nearly said the phrase that I always say, which is that we have waiting lists within our system because we have a system that is set up to create waiting lists. Our system is really designed for waiting lists, so it is no surprise that we recurrently end up with long waiting lists. I mean, again, just on what Richard is describing, I mean, there's absolutely no question that we've got a backlog. We need to deal with that backlog. But this is much more than that. This isn't just about buying more and more capacity. This is about how the system works together. This is about understanding the demand, not just simply plowing more and more capacity into the system. So understanding the demand and creating those various pathways, particularly around the urgent and the emergency sort of situation, which is the case that strikes fear into every GP of those patients that we see and that we know need seen quickly and investigated quickly, but labour on waiting lists and all of the consequences of that. So it's about designing those pathways very much around the patients and how we deliver the services vastly different to how we're delivering them at the moment.
Okay, thank you, Alan, for that. I think we need to keep moving, folks. I'm conscious of time, but nor do I want to stifle what's a good discussion. But move on to the next question, which is on an area that's already been touched on a few times with mental health, a really important issue. And obviously the appointment yesterday of the mental health champion represents a significant development. But Petra Kaur, who's head of psychological services and occupational health and wellbeing for the Northern Trust and has been doing some really great work regionally over the last few weeks. Petra, can come to you and we'll address this question to Charlotte, please.
Hi, Michael. Thank you. Can you hear me?
Can hear you okay, and we can now see you.
Excellent. That's great. Thanks. Charlotte, obviously we've already started to see some of the signs of mental health impacts on our health and social care staff and across the wider population. What are your thoughts on approaches that we can take to address these issues moving forward?
Thanks, Petra, for that. I suppose I would start by saying that we were never really in a very good place to start with. So, you know, with 1 in 5 people in Northern Ireland having a mental health issue over the course of their life being much higher than it is in other countries compared to the UK, you know, we're dealing with a difficult situation in mental health, which has been underfunded as well for many years. So the ability to respond is more of a challenge, I suppose. But I think that a starting point for me is about strong public health messages from here in relation to COVID, modified obviously for individuals' needs. But you know, we've heard reports of many people increasing their alcohol intake, for example, during the period of COVID, and we know that there are clear links between alcohol intake and mental health. So we need to send out strong messages in relation to that. But many people, I think as Richard said earlier, will have lost their job during COVID. So as well as, you know, losing a sense of purpose and an income and their ability to provide for their family, many feelings associated that would be quite normal. And I think we have to demedicalize those and not label people as being mentally unwell. And I think it was Seamus that used an expression about non-well-being. So again, sending out a message that it's okay to be not okay after COVID and destigmatizing mental health is particularly important, I think, because so many people are feeling very normal effects from what has happened to them during COVID. The one thing that I do know is that the crime rate during COVID has decreased, but in domestic violence it has increased. And again, that's a very significant fact in terms of people just trying to manage their way through the COVID. So again, I think we need to be very mindful and aware of that and put in place strategies to pick that up and deal with those issues should they present themselves to us. And obviously, the whole area of children, and I know Sean will address that later, vulnerable children and people living in poverty, and the impact that we know that ACEs have, particularly, you know, more than 4. There are going to be many children who have lost parents or grandparents or have had traumatic experiences during COVID that we also need to take account of and deal with. So, and aligned to that, I think, is good mental health, because the two go hand in hand. So we need to be encouraging people to get out and exercise and walk and cycle and all of those things that have so many other benefits other than your physical health in terms of looking after their mental health. And I think for us going forward, obviously the announcement of the mental health champion yesterday is a huge step forward, and I know that Siobhan will be very vocal in terms of how we manage some of these issues going forward. And I think there's an opportunity probably where we need to educate and provide some awareness training for staff, because many of our staff who maybe wouldn't have dealt with people who are not feeling so great will now be facing them in all sorts of areas of our practice of our service. So we need to give them some tools to deal with that and intervene, and yourselves and your colleagues in psychology are well placed to do that. And the other area that I think we need to focus on is rehab for people who've had COVID, because the rehabilitation period for some will be very, very long, particularly for those who've had a long stay in intensive care, a year plus. And again, the impact on their mental health will be significant. So, and I think your rehab strategy, and I know the HPs have done a lot of work on that across the 4 countries, but I think particularly HPs are well placed to lead that, and particularly occupational therapists who have that joint ability in terms of rehabilitation, but also mental health. We need to find ways to promote that work and very defined pathways now for rehabilitation post-COVID. And then on the acute side, I mean, we're already seeing acute mental health services come under huge pressure for the last few weeks, where they had seen a bit of a decline, I think, during COVID, where people were, for whatever reason, not engaging with service or didn't want to expose themselves to situations that they might find put them at risk. So now those people are all re-engaging and are on a hugely complex patient group in our acute mental health wards, but we also have problems with workforce and bed availability. And so going forward, we need to develop new pathways for mental health. We need to make sure that people are not institutionalized and in acute care when they don't need to be, and I suppose to help us manage those pathways out of acute care. Again, I talked earlier about partnership with the independent sector, but in this case the third sector, which might be very helpful in supporting people in their own homes. But a really strong role here for multidisciplinary teams in primary care, and I suppose primary care being the gateway to healthcare. That's where many of these issues are going to be identified, and early intervention will be key to helping them. So I think key messages are to demedicalize mental health issues, to tell people it's okay to not feel okay right now, and to provide strong public health messages.
Thanks, Charlotte. Petra, is there anything there that Charlotte said you would like to respond to, or any other thoughts you have?
No, that was a very comprehensive and full answer, Charlotte. I couldn't agree with you more. Very, very much signed up to all aspects of that. I mean, I think it's really important for us to normalise the responses. I think it's really important for us to connect our services, and when people do need help, to consider early intervention, really intervening as early as possible, and thinking about the supports as close to where people are. And trying to avoid the long waits. And then obviously when people do require comprehensive and full secondary care mental health services, for those to be there and fully responsive and able to provide evidence-based care to people who need it. And again, just highlighting the importance for our workforce, training our workforce up to support that mental health need that we're going to see across all areas, but also being very mindful of the impact of this really difficult time on our own workforce, and really encouraging people to use the resources that have been created for the workforce on the PHA website, and encouraging all of us to take time and to look after ourselves. So I totally agree, Charlotte. Fantastic response. Thank you.
Thank you, Petra, and thanks, Charlotte. Our next question is in relation to the whole issue of working together, much more collaborative working, and so on. It comes from Jane McKim, who's Head of Communications with the Southern Trust, and we'll ask Jennifer to initially respond to this. So Jane, are you there?
Yes, I'm on and listening interestedly to the conversation. I'm going to talk about working together, and it is interesting, but the working together theme has been the whole way through this debate. And clearly it's been a key element of how we have moved through the last few months. So particularly in the early phase of the pandemic, I mean, there was really amazing sense of working together. You know, I think we all worked outside what would be our normal hierarchies, our own organisational boundaries. And I think the evidence of how we've actually managed the whole COVID thing is evident in how well that worked for us. I think given what's so clearly been articulated today about the task that is facing us, how do we keep that? How do we preserve that culture? Or do you think that we will just end up back to where we started, and that we really won't have moved forward?
Okay, thank you, Jane. For me, I think it's not simply a matter of can we preserve this culture. I think we must preserve this culture. I think it is vital to us all going forward. I think the really positive thing out of this, and you've referred to it there because it's come out from all of the things that we've been saying, I think there have been closer working relationships across all of our health and social care sector than there has ever been before. And it's interesting, the very first meeting of the Rebuilding Management Board that took place, all of us reflected on how we had been working together. All of us reflected on how we had worked across boundaries, whether that was primary, community, secondary care, or whether it was the statutory sector with the independent sector and community and voluntary sector as well. So things really have changed. At a very practical level, at the height of this, chief executives of trusts were coming together 3 times a week to talk about practical issues and how we navigated our way through that. We've kept that going. It's twice a week. It's been the same in terms of the interaction between the chief executive group and colleagues in the department. And that has been really, really, really welcomed. So I don't think any of us want to move away from that. In fact, we have all really commented that that is the way that we have to continue to work. And it does feel like a really, really collegiate response. And I think the other interesting thing is then, I'm going to give you 2 specific examples of where I think we can really make a difference. And one of them is around urgent and emergency care. And we've had different papers coming to the management board, but effectively we've all been saying the same thing. And we're bringing all of this work together now. There's a real opportunity across the entirety of an urgent and emergency care pathway, or a continuum of care for a patient, where we can look across general practice, GP out of hours service, making sure that there's direct access into the secondary care services that are needed, looking at how we create urgent treatment centres, looking at how we create ambulatory care pathways, eventually through into emergency departments. And for the first time, it really feels like there is not just simply a willingness, but people really wanting to come together to reshape our system and deliver this in a different way. And there's a real energy and purpose about that, which is incredibly exciting. And the other area that I would mention is in relation to care homes. I think we saw some fantastic work over the course of the pandemic, where we had people for, again, right across our health and social care services. So we had the independent sector who are running the care homes. We had general practice coming in. We had multidisciplinary teams from trust in terms of nurses, social workers, infection prevention and control leads, and so on. Everybody coming together to work in a different way and to really do the right thing. And obviously Charlotte has been asked by the Minister to take forward a particular piece of work in relation to care homes with all of those sectors involved. So there's going to be rapid learning coming from that. So I think, Jane, in response to your question, I think the pandemic has been a turning point for all of us. We have seen what we have been able to achieve because we've come together. I think we all know we wouldn't be in as good a position as we have been if we hadn't come together. There was a necessity about it, and we all are very keen to make that work and to continue to make that happen. And I'm confident that through the Rebuilding Management Board, we'll not go back from that. There's a willingness to work in this way going forward.
Thanks, Jennifer. As you say, we just must keep working in that way. And I think one of the things we must do in that is not lose 2-3 months and almost have a bit of everybody taking the foot off the accelerator a bit for 2 or 3 months, and those ways of working go back. It would be much more difficult to restart it again. We just need to keep going from where we're at. Just before we move on, anybody else from the panel want to comment briefly just on that particular issue before we move on?
Michael, could I just say very briefly from my perspective, and forgive me if I misinterpreted, but the premise of the question is, if we don't do something, people will go back to their normal behaviours. Just to say, I think the normal behaviour of people is to reach across boundaries and work together. I think I come at it the other direction. We've created a system that makes it difficult for people to reach across boundaries. But speaking to Sean Holland in many cases, simple example, social workers, it's just in their DNA to reach across to partners in education, communities, and justice where appropriate. And it's true for both across sectoral boundaries, but across organisational boundaries. We have made it difficult. So for me, the challenge for the management board is about enabling, facilitating, and providing permission. It's not about cajoling staff to do something that's not inherently within their desire to do.
No, it's a very valid point, Richard, and I suppose that highlights that if we don't provide that permission and authority for people to do that, it really is a terrible waste and something that we'll regret. So encouraging that is the way people want to work, and our job is to facilitate them to do it. So thanks for that. If we move on, our next question is from Seamus Mullen, who's Head of Health and Social Wellbeing Improvement with the Public Health Agency. And Seamus has got a question in relation to health inequalities. So Seamus, are you there? There you are.
Yeah, thank you, Michael. I suppose a number of the contributors have touched on throughout the meeting earlier about the impact of poor health and wellbeing on the population. But as we all know, that doesn't always affect people equally throughout our communities. So COVID has potentially brought a stark focus into the impact of health inequalities, and we fear at times that it could exacerbate those health inequalities. So my question is sort of system-wide: how can we as a system redouble our efforts to address those health inequalities? I know it's for someone like me working within health improvement, it's bread and butter to the work that I do and that my division does on a daily basis in terms of partnership, working with other government departments in the third sector we've talked about. But how do we do that on a system-wide basis and redouble our efforts on it across health and social care?
Thank you, Seamus. And I should have said, if we ask maybe Charlotte to lead off on this, and I know maybe Alan might want to say something, and Sean may also wish to add, but Charlotte, can we start off with you, please?
Yeah, thanks for that question, and I think it's a very pertinent question. And I suppose for me, I'd start from the premise that health is a fundamental right, and equity to health services is a right for all of us. And when we look across Northern Ireland, we might, I suppose, initially think that we have everybody has equal access and equity to health service, but in fact, we know when we look at the population profile that isn't true, that there are those, particularly in the most deprived areas, that often don't have the opportunity to engage with health services, or for whatever reason, and because of what's going on in their lives at the moment, don't engage with the health services. So we do have to redouble our efforts. And if we look specifically at the social determinants of health, and I'm doing a piece of work at the moment with Michael which we're born into and we live in and we grow, affects our ability to have equity to health, and also our ability to thrive. And we know that when we think about COVID, there are clear links between health equity and determinants of health, and for example, gender. So we know that COVID is more likely to affect men of particular age. We know that the BAME community have particular issues with their health and COVID. We know the things like your income and your housing affects your underlying health conditions and long-term conditions, and we know that people with long-term conditions are obviously more susceptible to COVID. So I think there's a direct link between COVID and people who have health inequalities, and therefore, and I think it's also interesting that in the UK at the moment, this is the first time in 100 years where the life expectancy of the poorest 10% of the population hasn't actually improved. So we're static, and we run the risk of following COVID of going backward unless we double the efforts, as Seamus has suggested. And I think how we look to do that has to be through community engagement and community involvement. I think the community development plans that were developed under the transformation programme now need to be accelerated. We need to co-produce those plans with local communities, taking account of what's important to them, rather than us as healthcare professionals telling them what we think they should be doing, because it has to be based on their own individual and collective experience to enable them to take responsibility for their own health. I think immunisation is going to be really important going forward, not just to maintain our very good rates of immunisation up to this point, but also thinking about vaccination for both flu in the winter, but also potentially for COVID, and how we get a vaccination programme that can be scaled up so quickly to cover the whole population for COVID. I think particularly in terms of improving the health of the population, for me, my priority has always been about children, because they are the group that are going to have the greatest gain, if you like. There's many of us on this call, we've already established our patterns of behaviour and our long-term conditions, and in some ways we've limited opportunities to change that. But for children, if we really take this opportunity, we can influence their health outcomes for the future, and I think we should focus our attention there going forward.
Thank you, Charlotte. Just give an opportunity, and I would ask you to keep it brief, folks, because I want to leave a bit of time at the end for general discussion. But anybody else in the panel, thinking particularly maybe of Sean or Alan, want to make just a brief comment on the health inequality? So Sean has appeared. So apologies that we managed to block you out, Sean. Last person we would have wanted to do that to.
No problem at all, Michael. Just picking up on the point about inequalities, it's not just health inequalities. Social inequalities can translate into lots of bad outcomes. And over the past couple of years, we've had an increased understanding of the relationship between poverty and the likelihood of children coming into care. For probably the past decade, we've focused on things like parental alcohol and substance abuse. We focused on domestic violence and parental mental ill health, and seen those as major determinants of children needing to come into care. Actually, they are by no means as significant as poverty. Paul Bywater has done some great research, and its Northern Ireland component to it, and showed that the most significant determinant of a child likely to end up on a child protection register or come into care is actually poverty. And we really need to recognise that and start addressing it. I think for my own profession, we've probably spent the past 20 years becoming more and more focused on individual casework, pathologizing these kind of things. And I think we now need to pull back from that and rediscover things that Charlotte was talking about community development. And I think we've got a great opportunity. I mean, we're the first part of the UK who've introduced an anti-poverty practice framework in relation to children's well-being. I think that's a great step forward. But I think the MDTs are starting to show us how we can start taking this broader approach. We're getting some early case studies and evidence emerging from the MDTs, where generalist practitioners within MDTs, generalist social workers, are able to have a real impact on addressing things like deprivation and inequality, and trying to resolve them or ameliorate them through community-orientated approaches, as opposed to pathologizing parents and saying, you're bad parents, we're going to take your children away from you. So certainly I think that a lot more to do, but I think that we've got some very exciting and interesting developments in that space.
Thanks, Sean. I know we'll return to you shortly to hear more, develop more in relation to social care. But Alan, do you want to make a brief comment on that before we move on? helpful?
I mean, very briefly, Michael, just to agree with what Sean and Charlotte have said. I mean, this is something that we see really starkly in practice. I think the question, Amos's question, was specifically about COVID and actually the emotional, the financial, and the health impacts that we are now seeing in practice at such an early stage is truly, truly frightening, and it is having the biggest impact on the same group of patients that we are talking about and those most deprived. And again, just to emphasise, I won't go over it in detail again. This is about shifting the model. It's got to be a proactive, preventative, educational model that is a non-medical model. It's got to be out in the communities and it's got to be supporting and signposting patients and the public to the right service at the right time. If we continue to just put it into the traditional medical model, we're not going to solve this problem.
Okay, thank you, Alan. And our next question, which comes from Paul Rooney, who's professional advisor with NISC, follows on neatly from that, I think, and it is a question for Sean. But Paul, are you there? There we go.
I am, Michael. Good day, everybody. Sean, social care has been perceived as a secondary priority and indeed a periphery workforce in some instances. With social care issues becoming more apparent during the pandemic crisis, what changes do you think are required now in the wake of the pandemic?
Okay, Paul. Firstly, yes, I would recognise that social care sometimes has had a secondary role, but I have to push back and refute absolutely, because it's been suggested by some commentators that in this crisis, all the focus was on the acute sector and we forgot about social care. We didn't. Whatever the outcomes were, it wasn't because no one was thinking about social care or care homes. That was something that was a focus from the very beginning of our move into a gear where we were starting to actively prepare. In terms of where we go next and what we learn from it, I mean, Jennifer talked an awful lot about integration, and I think that's one of the things. Richard has never quite let me forget that at a NICON event, I once compared health and social care integration to a B-Day. And the point I was making was everyone's pleased to have it and thinks it's a good idea, but no one's quite sure what to do with it. I think one of the things about COVID is it showed us what you can do with it. The way we were able to wrap trusts around care homes was unique in the UK. We did it in a number of ways. I mean, we provided nearly £15 million worth of PPE directly to care homes. We didn't get into, I mean, in England, they set up a logistics chain and a supply chain, whatever. We simply told the trusts, listen, treat them as if they are part of your own organisation, wrap your arms around them, allocate them PPE as if they were a division of your own organisation. We also worried, understandably, one of the main things we focused on when we were planning at the beginning of the outcome was about staffing. We knew we were going to face staff vacancies. Some of the care home operators are relatively small. They don't have the resources to call on huge staff resources when people go out sick. So we did the same thing. We said to the trusts, wrap yourselves around these care homes, provide staff. Now, it wasn't without challenges, but we couldn't have done it if we didn't have an integrated health and social care system. There wasn't that kind of relationship between the NHS and local authorities in the rest of the UK. We were able to do it. And we were also able to support that sector with statutory bodies. I mean, the PHA and the RQIA both provided phenomenal direct support to care homes throughout the surge of the pandemic. We need to make sure we don't lose the lessons of that in terms of integration. But there are a few other things. One of them, I think, is place. We need to understand the relationship between providing social care and places where people live. We saw an outpouring of community support and goodwill towards social care. And I think we need to make sure that we start to maximise that relationship between a community and a provider of social care within that community. Now, that's really difficult when the social care is being provided by an organisation which is owned by one of 126 companies, owned by an overall corporate body registered in the Cayman Islands. It's very hard for a community to have a direct relationship. So I think we need to start looking at ways of having a closer connection between the providers of care and the communities within which that care is provided. A really practical issue for me, though, and it's not unconnected to the previous point, is size. There was some evidence before COVID. There is now some very specific COVID-related evidence that very large facilities did not do as well as medium and smaller facilities. Once you get over 60 beds in a residential unit, there are issues. Now, I think for a long time people have argued that there are issues around the personalisation of care in very large facilities, but there are other difficulties as well. So I think we should be exploring the issue of size as we go forward. The other issue, I think, is outcomes. We've spent a long time digging ourselves into a hole where the relationship between trusts and social care providers is a contractual relationship, and it's governed by we give you X amount of money, you give us X amount of minutes of care. And that's not right. That's not the way to do it. Now, very early on in the pandemic, we realised and recognised that a lot of people were turning away their domiciliary care workers. They didn't want to let people into their houses. Now, ordinarily, we would say, no visit, no money. But we knew we had to sustain that service and we were going to need it again. And so what we did was manage to quickly move to something we've talked about for years and say, focus on outcomes. We're not going to measure you simply by the contract metric of was a visit done, was it completed on time, how many minutes were you there. We said, okay, we're going to pay you the money anyway, but try and be creative and focus on an outcome. So if someone won't let you into the house, can you talk to them through the window, make sure they're not socially isolated? Can you even make sure that they have enough shopping there? Can you check that they have other contacts, that they've got other supports? Otherwise, we were moving from that time, money, contractual, transactional relationship to one which was saying, listen, we'll pay you and deliver an outcome. Now, I think we need to hold on to that and transform particularly domiciliary care into a model that is more focused on outcomes than those simple transactional relationships. The other thing is that when we introduced the community care reforms in the 1990s, we said we were going to have a mixed economy of care. We've lost that. The reality is that the vast majority of residential and nursing home care provision is from the independent sector. Now, even before the pandemic, we'd had situations where care homes were looking like they were on the edge of failing for a variety of reasons. And there were private companies, and we had to look at how we could quickly respond to support those care homes. And our response was largely one about finding other private providers to try and take over the service. Now, in the context of the pandemic, we also had this situation where sometimes care homes didn't have the staff to run the home, and we had to supply those staff. Now, people did an absolutely fantastic fantastic job, and I particularly commend a lot of the nurses who were used to working in very different environments, who stepped up and went into care homes and delivered services. We talk about the concept of comfort zone. That is really working out of your comfort zone, and they really are to be thanked and commended for doing so. But what it brought home to me was that we don't have the in-house expertise and knowledge of running a care home that would have been useful. If we had a truly mixed economy of care, where some of the care home provision was actually within the statutory sector, I believe we would have inbuilt the knowledge and skills that would assist us in being able to go in and respond and support care homes even more effectively when they're in crisis. And then the final point I would say is a straightforward one, and it's value. We need to start valuing this. I said it before, and I don't want people to misunderstand this, but you know, I've checked. It costs more to get a dog walker per hour in Belfast than it does to pay for an hour of domiciliary care. Now, we all talk about how we value the vulnerable, how we value the elderly, but we're not putting our money where our mouth is. And this certainly has to be linked to reform, but it's not just about reform. If we're going to make sure that we've got a sustainable, resilient workforce, we have to get away from the situation where we've got 30% churn because people can't afford to stay in it. I know there are huge demands on resources across every aspect of services. We talked about this at the management board, and it's going to be very, very difficult. But you know, the lowest paid people in the entire system, we really need to think about them, and that's care workers. And I think we need to address that.
Thanks, Sean, and a sobering thought at the end, if indeed that is the case, which I'm sure it is. Paul, anything you'd briefly like to respond to what Sean said?
Yes, I agree, Sean, and I think Seamus alluded earlier on about how we utilise people right across the system to make sure we do better. I think the pandemic has shown social care in a light that we probably haven't seen before, in terms of the depth and breadth of the skill, and that it's a high skill area of work, and not as would perceived previously as more low skill. So the value, a valuable workforce, and one that needs to be valued.
Absolutely. Thanks, Paul. Thanks, Sean. Folks, again, just mention, I know we've said it, but in case some of you missed it, we are clearly running over. If you need to leave, leave, but we think it's worth the conversation's good. We think it's worth keeping going for a bit longer. We'll save a little bit of time at the end, but with a few more questions, people have put them in. I want to give them the chance to ask them, but for these final few questions, if I could ask those answering them, please to just keep your responses as brief as possible. Next question's from Maura Briscoe, a non-executive director with the South Eastern Trust, who's got a question in relation to the new governance arrangements around the establishment of the management board, which we'll ask Richard to respond to. But Maura, can I ask you to pick that up, please?
Yes, thank you. Good afternoon, Richard and everyone. My question relates to governance and corporate accountability, and we recognise the need for regional approaches and working together in where we are now and in the reset of services. But in the context of the management board, how are major decisions going to be made? And where is the balance between decisions made at management board and responsibilities in relation to roles and responsibilities of, for example, trust boards, and how is that going to play out, particularly where difficult decisions have to be made which may be unpalatable for local communities?
Thanks, Maura. I'm not sure that I see the issue in the same way in this, because and forgive me if I'm misinterpreting, Maura, but the premise of the question nearly seems to be there's a possibility of conflict between, at one level, the strategic and ministerial priorities, and at the other, the priorities at local level of a board. I think, particularly given the context of the last number of days, when there's a bit of media coverage about one of our arm's length bodies, it's maybe going back to first principles. The role of a board of a public body is to ensure that the policies and priorities of the minister are implemented. There seems at some time, particularly in the media, to be an emerging narrative that the role of the board of arm's length bodies is to develop their own set of priorities and maybe to take issue with the ministerial or executive position. So I just say that in terms of context, that I don't say that to suggest it's an issue that we've particularly experienced. The fundamental role of the management board is to bring, and the phrase I normally use is this degree of regional coherence to everything we do. I think we've touched on a number of times today. The way the system has come together has been, breathtaking in the degree that it's impressed many of us. The reality is it has saved lives, the systemic response as opposed to the organisational response. But in saying that, I think what the regional coordination does is it allows at the local level those individual more locality-based players to actually undertake the things that they truly excel at. Our colleagues in trusts excel in engaging with the local population and providing services at local level to their community. What the management board seeks to do is provide a sharper and clearer regional context for that. And it's also fundamentally about ensuring that when we develop a regional approach, that is undertaken across the regional. That's not to say that there isn't a space for some local variation around the margins, because there always has to be that space. But where there is a variation from the regional approach, it has to be grounded in the evidence. What is the need for that departure? Is it the appropriate departure, and how do we determine that? So and well, he would say this, wouldn't he? I can only see the management board as being a strength in our system. And hopefully I've laid this down, and it's for others in the management board to comment on this. But the challenge I give to them is if the management board becomes some sort of march past for the views of the department, it is doomed to fail. The management board has to be a safe space where those members of it can disagree violently with each other about approaches. The management board is the vehicle through which we develop and articulate advice to a minister to then take decisions which we all, come back to our organisations, have an obligation to implement. But if there isn't passionate disagreement and debate in terms of the formulation of that advice, we are all failing. So as I say, I hope that goes some way more towards answering your question. I see this as enhancing the system. I don't see that we're moving into a situation where directly from the department we manage trusts. We wouldn't have a clue how to manage the complexities of trust business. They're too big, too complex, and frankly too good at what they do. This is about a supporting mechanism to bring us all together and to work collectively to achieve the sorts of things we've all touched on today that we would point to as examples of success over the last 3 months.
Okay, thanks, Richard. In the interest of time, getting the last couple of questions, folks, I do plan to move on, but hopefully that response from Richard clarifies that position and is also reassuring, in particular his last few words on it. So thanks for that. Thanks for the question, Maura, and Richard, for your answer. Next question is from Dr. Martin King, who's a core surgical trainee in the Western Trust. He's also Honorary Secretary of the Northern Ireland Regional Representative Association of Surgeons in Training, which gives him the longest title of the day. It is touching on an issue that we have already addressed to some extent. So I'll ask Alan Stout perhaps to reply to this, but keep it fairly brief. But Martin, if I can come to you, please.
Hi, thank you very much, Michael. My question to you, Dr. Stout, is many of the staff and those that were previously now a part of HSC and I were outstanding in stepping up, making and leading change. But how do you suggest we can promote that level of engagement that we've talked about, the service being clinically led, managerial enabled? How do we promote that creativity and leadership going forward?
Okay, thanks, Martin. And Michael, I will be brief because my phone battery is about to run out as well. So if I disappear, that's why. I mean, in terms of leadership, Martin, I mean, this is stressed, and the challenge that has been presented to anybody in a leadership position has been huge, but the response has actually also been huge and has been massively impressive. I mean, what we've seen is a very disseminated leadership. So we've had people standing up and really taking on tasks and taking things forward. And I think it's been well covered already that it has stressed the system so much over the past number of weeks. But actually what we've seen as a result of that stress is people stepping forward in their relationships, starting to develop better and quicker than we've ever seen before as well. It's really, really important that there's recognition of the value and of the planning and of the need. I think Jennifer mentioned earlier about the energy and trying to maintain that energy. And I think we will maintain the energy if people start to see the product and if people continue to see that decisiveness and that speed of change and speed of implementation. I mean, we have a real risk. We've got, certainly in the clinical environment, I think in every environment, we have this real COVID fatigue that's coming out. But with the fatigue, we also have the enthusiasm. And the risk is that if we don't, see the changes as quickly as we want to, that the enthusiasm then becomes the fatigue as well. So I think it is very, very important. Richard mentioned earlier, and I jotted down as he said it, I mean, the key thing within the services is about trust, and it is about the decisiveness, and it is about us working together, which has been well covered already.
Thanks, Alan. And Martin, maybe just come back to you as a surgical trainee. What would your message be? What's your advice on it?
I think the theme of this is the response from the staff has been truly positive, and from my point of view, we've changed in terms of what we do as training and surgery. We've redeployed. We're starting to now be in this phase of starting to reinstigate services and doing things that we used to do in a different way. And I think there's been a huge element of collegiality, and that's been a real positive thing to see, being on the front line, and hopefully we maintain that going forward, because the engagement across disciplines is actually more beneficial in getting the goal, which is to deliver the best possible care. So hopefully that's maintained going forward in the rebuild.
Well, hopefully what you've heard in this afternoon's session, Martin, gives you encouragement that that will be the case and there's a determination to do it. So thanks for your question. And a final question is in relation to the whole area of innovation and new thinking in terms of technology. And it's from Dr. Andrew Hamilton, who's a consultant cardiologist, also the NIECR lead with the Southern Trust. And again, we'll ask Richard to address this one, please. So Andrew.
Hi. Thanks for giving me the opportunity to ask a question. There's been a really big rise in the use of digital technology such as Zoom and Microsoft Teams recently, and it's been great to see that the Encompass project has finally been signed as a contract so we can get going on implementing large-scale digital change. But there are a lot of pressures on time, and how can we allow time for this to embrace innovation and new thinking in the service when there's so many competing time requirements?
Okay, thanks, Andrew. It's good to see you again. I don't think the issue for us isn't so much about innovation and finding space to innovate. We talked about this actually yesterday at one of our management board meetings. Pre-COVID, I tried to get out into the system as much as I could, just to connect with people. And you know, it's all very well seeing the system from my luxurious office and castle buildings, but seeing real people do real work is important. Every single time I do that, I come back absolutely blown away by the level of innovation I see in our system. Everybody is dealing with complexity, and everybody has a set of tools, and everybody I see is trying to flex and amend those tools, embrace new and emerging technology. So I think the innovation is there. I think where we as a system, not as individuals, but as a system, where we fail miserably is the adoption of successful innovation. We have many pilots which are impressive. We rarely take those to scale at a system level. We certainly don't do it quickly. So I think my focus would be more being encouraging evaluation and adoption of innovation rather than innovation. I think we need to continue always to make colleagues aware that we are a system that aspires to innovate. Again, it's about permission and authority. You touch on Encompass. I'm delighted to see Encompass signed. If I'm honest, I'm also absolutely terrified as the single biggest IT project to be done. And we all know the success rate of major IT projects. I have a large measure of comfort from the preparatory work that has been done in Encompass and the clinical engagement that's taken place on that. There is a genuine sense of excitement across our system. But in terms of linking that to innovation, Encompass will fail in terms of what we want from it if it becomes the digitalization of how we work. Encompass has fundamentally got to drive new and different ways of working. It's got to change pathways. It's got to play into that regional space. So I think the short answer is, I think the mindset is there about innovation and new thinking. It's about continued granting of permission and authority and support and encouraging innovation from my perspective. I often tell the story that as coming in as permanent secretary and accounting officer into a department, normally the first thing you encounter is the team of people whose job it is to stop you getting into trouble and stop you being criticized for things. If we're serious about innovation, we've got to recognize we need to be serious about recognizing we're going to fail. Not if every form of innovation was successful, it's not true innovation, it's just marginal improvement. True innovation is a risky business. It needs to be measured and appropriate risk, but it will lead to failure. And people like me have got to be prepared when we do have the odd failure, if we're true about innovation, to stand up, take responsibility for that, take that on the chin in the likes of Public Accounts Committee, but continually provide support and metaphorically help people back to their knees, dust themselves down and have another go. So there's a big cultural issue about innovation, there's a big support mechanism, but I would really want to switch the emphasis on the adoption moving forward. I hope that's helpful in some way.
Yeah, I think so. Yeah.
Anything you want to briefly say, Andrew, on that in response, or you can?
I think there's a tension between innovation and the desire to have encompass weeding out variation by having single regional ways of working. And I think it's important to hold those two things together, because I think we will see great benefits from having single pathways for treatments of conditions across North Ireland, so that everyone is treated in each hospital in the same way, because I think there's a great efficiency to be gained from that, and that removes unnecessary tests and procedures and delay in the system. And I think that's the difficulty in where innovation fits in whenever we are moving much more towards unified ways of working.
Okay, could I just briefly, Michael, respond to that? And Andrew, please excuse me emphasising for effect. There has got to be scope for departure from those standardised pathways, but it's got to be on the basis of firm evidence of improved outcomes. My emphasising for effect is, forgive me for the number of times I've heard a very senior doctor say, I'm not doing it that way because I prefer to do it this way. Zero evidence base, loads of personal prejudice and preference. That's what we've got to rule out. But it can't ever be a true one-size-fits-all approach in our system. It's got to be, our starting point is this is the way we do it. But there's no point in having highly expert, highly trained, highly competent professionals such as yourself if we don't say and recognise there will be cases where that isn't appropriate. As long as we're certain the justification of that departure is better outcomes for the people we serve, I think we're all in the same place.
Yeah, I think Encompass will give us the ability to get the evidence base for those departures better, and that's where the key benefit of it is, I think.
Yeah.
Okay, that's a conversation that should clearly run or maybe merits a session on its own at some stage. So thanks, Andrew, for the question, and Richard for your response. Indeed, thanks everybody who's asked questions. That brings us to an end those, but I think there was a real good broad scope of questions that covered off a number of really important issues. So I'm sure everyone has found that very useful. So thanks for the questions, and thanks for those who dealt with them so ably. It had been our intention, folks, now to just allow a bit of time where Heather was going to outline some of the key themes and messages coming through from the chat function, and I've seen there's been loads of it, so thanks for that. We're not going to, in the interest of time, because I don't think we can start that and quickly close it down. What we will do is summarise those and issue them to you. I think the general sense from this, with the number of people who get in, who participated, and the number of issues coming through, is there's probably an appetite for doing something like this on a fairly regular basis. So if that's the sense, we're more than happy to arrange it, and maybe some of those comments that have come through on the chat we can build on in future. So just by way of bringing it to a close, what I'm going to ask each of our panel members, I think there's 6 in total, literally, folks, in 20-30 seconds at most, would you just give a closing comment on your overall reflection and hope looking forward as to what we really can benefit from over the last few months and move forward more quickly in the weeks and months ahead. So can we start Jennifer, with yourself, please?
Yeah, so I'll leave you with a brief sentence, Michael, and it's with challenge and adversity comes opportunity. So for me, I think we can't afford to waste this opportunity that we've got.
Thanks, Jennifer. Succinctly put. Seamus, come to you next.
I suppose the overriding feeling I have, Michael, is I'm just so proud in the HSC family. We have incredible staff who've done incredible work over the past few months. I have every confidence that with our enabling, they will rebuild service, take the opportunity to transform as we go along.
Great, thanks, Seamus. Alan, if your mobile phone is still get charged.
Just about, Michael, and again, very briefly agree with Jennifer. I think massively encouraged. It's just a consistent message. I mean, I think across all of the questions and all of the answers, I think we just need to build on this opportunity. We need to build on the relationships that have very rapidly improved and developed, you know, in this this time period.
Good, thanks. Charlotte.
Thanks, Michael. I would agree with what's been said already. Totally inspired by what has been achieved. At the same time, not surprised, because I know that's what the system can do when we put our shoulder behind the wheel, and huge opportunities to keep it going now, even though we're all feeling a bit tired. But you know, real opportunities to keep this going over the summer and for the future of our health services to improve the outcomes for our population.
Great, thank you, Charlotte. Sean?
Yeah, I think if before this happened, you asked a lot of service users, they would complain about falling between stools. Too often they would come up against services or individuals who would say, that's not really my job, I think it's someone else's job. The experience of the pandemic was we forgot about that. And we all stepped out of roles and we focused on providing what was needed, where it was needed and when it was needed. And we worried about those organisational, professional and specialism divisions a little less. I think we need to hold on to that.
Absolutely, thanks. And Richard, I can give the last word to you to maybe leave us all on a high.
Oh, well.
No pressure.
No pressure. Just briefly, Michael, I mean, can I say by way of contact that I spent a career in public service, and, you know, prior to the 1st of July 2014, when I had a sane and sensible life out with health and social care, the truth is I spent a career saying that my job as a leader was to continually remind people of their objectives, to crack a whip behind them, to push things on, drive ambition, drive efficiency, and pursue outcomes. The challenge in health and social care, as I've been reminded again today, is fundamentally different. It's about trying to hang on to the coattails of giants in our system who are absolutely certain what the outcomes are. They're about improving the lives of the people we serve. They're about making the best use of technology and any and all resources that are available to them. So the challenge here is about trying to create the framework and the enabling context and environment for that to happen. And, you know, having, as everyone has, had 3 months of hell, when you reach the stage that says, sod this, I could have an easier life elsewhere, you go and organise a bloody event like this that just completely re-energises and re-enthuses you and say, I want to be here forever, because I will never meet a group of people like this again that it's a privilege to work with. So thanks for everything that's happened, and thanks for everything we're going to continue to do together.
Brilliant. Thanks, Richard. I think that is a really positive note on which to leave it. So the learning from us folks in NICON is not to be so ambitious. Too many questions. Apologies we didn't get a chance to bring more of you in. That was the intention. I can see from the comments coming up, there seems to be a strong view that people would like more of this. So we'll certainly look at doing that. Can I just thank again all of our panel who made themselves available and answered questions so openly and fully. Thank all of you for attending. We got up to 130 at one point, despite our initial problems, and I know people have had to leave as we run over, but thanks to all of you, and a big thanks to Heather and Megan from NICON for making it all possible. So if I could ask for 30, or not even 30 seconds, if I could ask you all to show your video again, just so we can get a screenshot that can be used on social media. So unless you're shy about that, please, everyone, unstop your video so that we can get a picture of everyone on the screen, and at that point then we will leave it and hopefully organise something similar in the not too distant future. Thanks again. Megan, are you able to make that happen?
I am indeed, yeah. Thanks everyone.
Yes. We're coming. I don't see it yet.
Megan, can you unpin Michael?
There we go. There we go. Get a few screenshots of that. And maybe scroll across and take the next screen, not leave too many out. Brilliant, folks. Thanks very much for your time.
Thanks.
Bye.
Thanks, Michael.
Bye.